shoulder pain is probably the most common thing that I see and treat in our clinic. So I want to talk a little bit about today about one specific type of shoulder pain that people come in with or they're told that they've had, and that is labral injury. So what I'm not going to be talking about in depth right now is traumatic labral injury. So what I mean by that are traumatic dislocations or slip and falls where there's much more than a labrum involvement. There's usually some type of banked heart or bony involvement as well, maybe a little bit of rotator cuff. But I want to talk specifically about people that are dealing with chronic shoulder pain. They get an MRI and they're told that they have a labral tear and really what their next steps are for them from that point on. So first off, what is the labrum? The labrum is a essentially stabilizer, a passive stabilizer in the joint. So the shoulder is commonly described as that golf ball on the tee. It's the most mobile and unstable joint in the body. So the labrum serves to help increase that surface area to help stabilize the joint even further. When you have some type of labral injury, and again, this is not also talking about, I'm also not talking about baseball labrum injuries because that's a little bit different. This is, again, specifically for the CrossFit athlete or the active adult. So that labrum, when there is some type of injury of that area, whether it's from chronic overhead lifting or anything like that, there essentially is a loss of stability in that joint. Now, what happens then is sometimes you don't even know. A lot of people are walking around with labral tears for years and don't even know it, and they naturally start compensating in other structures. And I think it brings in the question and conversation, is the labrum really the pain generator or is it other structures? And I'm a little more of the school of thought of it's some other structures that are the pain generator, like the bicep tendon or the rotator cuff versus the labrum. Now, when that labrum becomes injured and you start having some secondary things pop up, that's because those other structures are now taking over for the labrum. And as a result, you say you are dealing with some shoulder pain, you go get an MRI, and the MRI comes back saying, wow, you have a labral tear. And anytime anyone hears that, they freak out, they worry they have to get surgery. I'm very much of the school of thought that a lot of labral injuries in the chronic sense, not acute, like traumatic dislocations, but a lot of chronic labrum injuries do not need surgery. They need to be very specifically rehabbed in an aggressive manner, but they typically do not need surgery. That is not a fun surgery to go through. Anyone that has had shoulder surgery, let alone labral surgery, can tell you that. But a lot of times, it just is a time where we need to reset and get a better idea of how do we calm the joint down and then rebuild the foundational strength and stability from the supporting structures, because that tear is not going to change, which is fine. So the overarching goal of rehab more than anything is we want to be able to create the dynamic support from the muscular of the surrounding area, so the rotator cuff and the scapular muscles, so that whenever that golf ball has to move within that tee, it can do so in a nice, smooth rotation like that. What we don't want is we get to the point where we're doing a lot of overhead or rotational stuff, and when our arm goes up and that golf ball starts to move, it starts to migrate up or forward, and that's going to hit on the cuff tendon or the bicep tendon. So that's a lot of what rehab is. We find the protected ranges that don't bother them, and that's usually below 90 degrees. We do a lot of foundational isometrics and concentric eccentric work for the rotator cuff and scapular positioning, and then we just build up from there. And that really is labrum rehab. It's a very gradual and graduated exposure to stress in non-painful positions to previously painful positions. And again, in my experience, a lot of these should not be managed with surgery. Again, unless you're talking about traumatic dislocations, that is completely different.